things that we've done in the hospital, and some of them are so simple that you'd sort of wonder about it. One of them is about walking people to theatre. You know, you come in, we take your clothes, we take your glasses, we take everything from you, we tell you to sit there now, we'll do to you, sort of. And one of the things about it is that, why can't you walk to theatre? You're nervous enough without having somebody at one end of the bed and another person at the other end of the bed, and all you see are the lights on the way down, you know? So it's a sort of about people's dignity, etc. And, you know, sometimes they go in wheelchairs. Now, there is the piece around we need the bed when you get to recovery to put you in, to bring you back to the ward, so there has to be work done in the background in order to move you, because you won't be walking back. So we need to sort that one out. But there are practices then that had to change around portering, etc. And 62% of patients now walk to theatre. In paediatric, the parents actually usually carry the child to theatre, and they go into the anaesthetic area with the children. Waste is also an issue for us, and we have various different types of waste. We cyclotoxic waste, but we also have ordinary household waste. You have all the cardboard waste and all the rest. And part of this problem was that you know, they weren't filling the bins properly, and we were getting charged, and weren't segregating the waste. So you know, clinical waste is more expensive than the domestic waste, and etc. So just by filling the bins correctly, we were able to save 10,500. So what we got was a weighing scales that the company used, and we used the same one, so we know exactly what it was on the way out. This is around pump infusions. So, you know, some medication, saline, other things are drug infusions, pumps. But we had loads of different syringe drivers, the things that go into the pump. And so there's all that education and waste around it as well. And people were, when the thing broke down, they'd hide it behind a curtain and not tell anybody it was not working, and then they go to look for a new pump, etc., etc., and couldn't be found. So we have centralised, it's called a pump library, and we loan it out, and they get their proper pump within 15 minutes of the request, 24/7. So when the technicians go off from the equipment library at 5 o'clock, the portering staff cover thereafter, and we saved $1 million in 3 years on that one. And what we had an issue was that, you know, the children's hospital, when they came out to Tala, had 70 pumps. They rarely used them, but what they had, they held. And so, like, to get people to give up what the pumps was an interesting one to start off with. Now we service them all inside or on site. This is a piece, like I talked about, the rapid access clinics or one-stop shops. This is where people may have a suspected TIA. Now, a TIA is a stroke, and so we can treat these patients as outpatients. They don't need to be admitted. Oopsie, sorry. So you provide a rapid access outpatient clinic, and in the first 6 months, 99 patients are managed, and avoiding 623 overnight stays. And that would be our outcome for that, because apart from treating the patients properly, we needed to save the beds so that we can get the ED patients or get the turnaround in the beds. It's 1,000 to 1,100 a day is what a hospital bed costs. This is the trauma orthopedic clinic, and the byline was to get them gone in 60 minutes. And that's what the before and after kind of state maps look like. And there were loads of, I should explain that this is a very complex clinic where they have, you have the consultants, they have 4 rooms, then you have occupational therapists, you have physiotherapists, you have the clinical nurse where they take off the, if you have a cast on, you'll have to go, if you've taken off the cast, they x-ray you first, then they take off the cast, then they x-ray you again, see if they need to put it on again. So there are loads of different people involved in it. And it's a busy clinic where it starts at 9 o'clock in the morning till 12:30, and there are 80 patients every day, Monday to Friday. and a lot of them are elderly and they're on crutches, etc., etc. So, and it's a tight area, and they normally had to register miles away from where it was, and then find their way, and you know, people get lost in hospitals and all the rest, etc., etc. And so the other thing was the complexity. So we needed to level the loads. You know, some people might have just needed to come back for the doctor to say you're fine and a discharge at your GP. Other people needed to have all those other complex work happen, and they were all one after the other. So there was no viewing of what the complexity was, and to reduce the waiting times. People didn't know when they came to the clinic where they were going next. So there's a huge thing when people sit in outpatients department in case somebody jumps ahead of them, or you know, because you're sitting there for long periods of time, you've nothing else to think about, right? So they want to know where they are in the scheme of things, and how soon am I going to get out of here, or when am I going to see the doctor, or whatever. And so we got a magnet board, and each of the magnets had a number on it, and we put all the various different sections up, and we moved the magnet as they went to the various sections. So they, instead of disturbing the nurse in her work, they just came and looked and see where they are. And strangely enough also, they didn't want to be called by their name. Some people wanted to, and also I suppose with a lot of the non-national or foreign names, people weren't able to pronounce them properly, so some people got upset that they weren't pronouncing their names, so they just want to be known by the number. Some of the doctors had issues around that because they felt they were being disrespectful to people, but anyway, that's what they wanted. So we timed people in and out of the various different services and how long it took and all the rest. And there's the, by staggering the appointments and different patient flows, we could reduce the clinic times over the time frame. And there's what the reduction after the Kaizen. So 40% of the patients exited approximately 45 minutes. Prior to this Kaizen, it took, some patients were there for 3.5 hours. What it is all about is reliability.